So this is a very broad question, and I'll take the answers sequentially. I think that readmissions go in a number of ways, including all cause of things that you'd think are not preventable. I'll deal with those at the end. The first issue is who's the patient? Start with the patient, because some patients are going to be very, very able to take just a single piece of paper and run with it. And some patients at the other end are actually going to need very, very much more personal attention. So one of the things we need to do is try to figure out what the patient and family support system is. At the University of Virginia, we have a questionnaire called TEACH, T-E-A-C-H, and TEACH puts patients into categories of how they want their medical information. So do they want a lot of information? Do they want a little? Do they want it on the web? Do they want it in person? And we're starting to use that to try to begin to categorize patients of who needs what. So the first thing is start with the patient. What is the patient's support system? We know at one end of the spectrum that there are patients who are really ill, who have been readmitted before, who are over the age of 70, who are male. Males seem to take less good care of themselves than elderly women, who are rural, who have multiple comorbidities, other things going on, and who have demonstrated lack of medication adherence in the past. Those people are more likely to need personal support, more likely to be readmitted. So start with the patient. Figure out, assess the patient. Don't do the same thing for everybody. That's one. Then, obviously, you start in the hospital. So there are approaches in the hospital with discharge coordinators. Everybody, I believe, needs to know in writing what they need to be doing when they go home. That's the discharge coordinator's job. That's whoever is discharging the patient, nurse practitioner, physician. There needs to be a written record. Now, it's surprising that everybody doesn't get that, but that must happen. So that's a must no matter who you are. So they now have the discharge instructions. Then it starts to be a little bit different depending on the patient and depending upon the current hospital system. So what are things that are being done right now and what are their effectiveness? We know from a number of studies that the overall effectiveness in reducing readmissions of a number of items that have been done in the past is less than perfect. So, some of the things that are currently being done. A nurse calls the patient the next day, or a nurse even visits the patient the next day. Now, the idea that a nurse or nurse practitioner would visit the patient was pioneered a number of years ago by Mary Naylor at the University of Pennsylvania and is very effective. Even one visit of going home, helping the patient to get started very early. That has effectiveness. So a home visit, but that's 1 or 2 visits. So that's being done. The second thing that are being done are phone calls. Somebody picks up the phone, a nurse the next day, and says, "How you doing? Taking your medicine?" The whole telemedicine idea of a nurse or physician, usually a nurse, back home, on television, reminding the patient or on the telephone. Again, that concept has been used and is being used in a number of places with a variable degree of effectiveness. There are apps. There are specific apps that are on different, iPad or Android that help patients to remember to do things. So those are the sort of pretty standard things that are being done, and those things have variable degrees of effectiveness, but less than anybody would really like. So those are a start. Those results, you can reduce readmissions maybe 10, maybe 20%, and that's good. That's a great start. So that's where that starts from. Now the question is, and again, it's about the patient. That may be enough. That degree of support may be perfect for a number of patients. And I think the studies that have been done, the studies we've seen, unfortunately don't tease out the type of patient or the characteristics of the patient, rather than just saying, okay, such and such doesn't work to prevent readmissions. I suspect it works very well in some patients and less than very well in others. So that idea of either the app or phone calls or a single visit has been done and is helpful, but maybe not helpful enough. So then the question is, can we elevate that in a way that uses people? And there are two models that are out there. The Coleman model, that's been around for a while, works. Okay, and that model uses nurses, nurse practitioners, and social workers to make home visits, and has very well articulated goals and very well articulated outcomes, and statistically works. So I don't want to, because I'm about to tell you about Grandaids, the Coleman model certainly works, and what I would hope as we talk about another approach is to say what we need is data. What we need is comparative data. And my guess is, to repeat for the third time, it's about the patient. Some patients are going to do very well with the Coleman model. Some patients are going to do very well with a single nurse call. Some patients are going to do very well with a simple discharge instruction. Others are not.